Okay, Dr. Hamna, please read the scenario.
Do I read it aloud or?
Yes, please read it aloud for everyone.
Okay. So a 40-year-old man, Mr. Ali, has a headache for 2 months. Please take a structured history, focused examination, and manage the concerns. Vitals are blood pressure 150/90 and pulse is 75 beats per minute.
Okay, take your time now for 4 to 5 minutes and then we will start.
Okay. Okay.
Okay, your time starts now.
Okay. मैं दोबारा से करूँ सारा कुछ?
बिल्कुल.
Okay. Okay. Good afternoon.
Good afternoon.
I'm Dr. Uzair, one of the doctors in this clinic. I'm talking to Mr. Ali.
Yes, doctor.
Okay. Can I confirm your age, please?
I'm 40 years old.
Okay. So I have gathered from your notes, Mr. Ali, that you have a problem of headache. Is that correct?
Yes, doctor.
Okay. Can you tell me more about it in your own words?
Actually, doctor, what happened is that I have been suffering from this headache for quite a couple of months. But since last 1 month, it has increased to such an intensity that it is interfering with my daily activities. So that's why I am here.
Okay. Well, this must be concerning. I will do my best to sort it out and will guide you accordingly. So, Mr. Ali, have you noticed anything else with that problem?
For example, what, doctor?
Like vomiting, nausea,
No,
or any
doctor.
other complaint?
No nausea, no
Okay.
vomiting.
Okay. Do you have any other medical conditions at all?
Yes, doctor, I have been suffering from increased blood pressure for quite a couple of months, and it is uncontrolled despite I am on several medications.
Okay. Well, this must be concerning. Can you tell me, are you taking any kind of a medication for it?
Yes, doctor, I am taking these medications. One of them is losartan potassium, and another
Okay.
one is bisoprolol, and another one is amlodipine.
Okay. We'll discuss in detail about the medications later. Let's talk about your headache in detail first.
Okay.
Okay. Can you tell me that have you noticed any kind of complaints before you get the headache?
No, doctor.
Like funny tone
No.
of the. Oh, okay. Okay. Can you tell me where exactly the headache is?
It is the doctor in front of my head. You can see on the forehead.
Okay, okay. Can you tell me, is it sudden or do it come it gradually?
Gradually.
Is it persistent or comes and goes?
It comes and goes.
Okay. So how frequently do you get it?
Almost daily.
Okay. Uh, Can you rate it on the scale of 1 to 10, the intensity of headache?
Yes, doctor, it is almost, you can say 6 or 7.
Okay. Um, can you tell me, does it move anywhere, like at the back of your neck or anywhere else?
No, doctor, it is only in the front of head.
Okay. Uh, is there anything that makes it worse?
No, doctor.
Is there anything that makes it better?
Sometime painkiller, but mostly it is always there, even after taking painkiller.
Okay. Have you noticed fever or fatigue along with it?
No, doctor.
Any lumps or bumps anywhere in your body?
No.
Any weight or appetite changes?
Yes, doctor, you can say I have gained weight. My friends and family are saying that I have gained a couple of pounds in the last few months.
Okay. Do you think it is somehow associated with the headache, like the time when you started having headache, you started gaining weight?
Yes, doctor, you can say because I'm having this problem for last couple of months.
Okay. Do you have any problem with your vision?
Yes, doctor, I have some blurring of vision.
Okay. Is it blurring of vision or double vision?
Blurring, no double vision.
Okay. Any other problem with eyes, like watering or pain in eyes when you get this headache?
No, doctor.
Okay. Any problem with ears?
No.
Any recent problem with the teeth?
Sorry, what?
Any problem with your teeth?
Uh, I'm not sure, doctor.
Okay. Any pain in jaws
No,
or pain during chewing?
no.
Okay. Are you left-handed or right-handed?
I'm right-handed.
Okay. Have you got any head injury before this?
No, doctor.
Okay. Can you tell me, do you feel any kind of a numbness or tingling in your legs?
Actually, doctor, it is pains and needle-like sensation in my hands.
Okay. And for how long you've been suffering from this problem?
Almost 1 month.
Okay. Any weakness in your arms or legs?
No,
Okay. Did you ever suffer fits or did you collapse?
no.
Okay. Okay. Can you tell me, is there any specific time when you get the headaches?
No, doctor. No specific time.
Any problem with your balance when you walk in a straight line or when you close your eyes?
No.
Okay. Let's talk about your general health. Can you tell me, is there any kind of a past medical history except hypertension that I should know?
No, doctor. Only hypertension. Basically,
Okay.
increased
Are
blood
you
pressure.
okay? Um, can you tell me in detail about the blood pressure? What readings do you check it regularly?
Yes, doctor. Mostly the upper one is 140, 150, despite taking medications.
Okay. Do you check it yourself or get it checked by someone from a
Uh,
medical professional?
yes, doctor. Medical professional.
Okay. Have you checked your blood pressure outside the hospital settings ever?
Yes, doctor.
Those readings were also high.
Yes.
Okay. You had been telling about the medications that you take, losartan, bisoprolol, and amlodipine. Is that correct?
Yes, doctor.
So, do you take your medications regularly?
Yes.
Okay. Um, do you know the doses of these medications?
No, doctor.
Okay. Can you tell me, are you allergic to anything?
No.
Okay. Any history of hospitalization for surgery or any kind of a procedure?
No.
Any conditions that run in your family?
No.
Okay. Um, I'm going to ask you certain sensitive questions that we do ask from all of our patients, and I want to assure you that they would remain confidential between you and me.
Okay.
Is that okay with you?
Yes, doctor.
Okay. So, Mr. Ali, do you smoke?
No.
Okay. Do you drink alcohol?
No.
Okay. What do you do for your living?
Actually, doctor, I'm a teacher.
Okay. So, how this headache is impacting your job?
Yes, doctor, it is impacting quite a lot because this eye problem and this headache both have put so much impact on my life.
Okay. Um, do you have any recent travel history or recent or in the past?
No.
Okay, where do you live?
In my home, doctor.
With whom?
With my wife.
Okay. Um, and do you drive, Mr. Ali?
Yes, doctor.
Okay. Have you ever noticed this that this headache stopped you while you had been driving?
Yes, doctor. Actually, what happened is that because of my eye problem, I couldn't see the things properly, especially on my sides.
On your sides? Okay. Okay.
So I have been having quite a lot of trouble while driving.
Okay. Okay. So let me ask, do you drink tea or coffee very frequently?
No.
Okay. Okay. Let me examine you if you are okay with.
Okay, doctor. Let me share you one thing. Is my screen visible?
Yes.
Okay, now start examination.
Okay. So I will start with general physical examination
Mm.
by looking at the general facial features, and then I will have the hand examination and look for the
Okay, what will
large
you?
size of hand.
Yes, yes, doctor. These are large, doughy hands.
Okay. Okay. Then I will check about the size of feet
Uh,
and
mm,
do the visual field examination
mm.
and visual acuity as well. And
Okay, how will you check VL equity?
well, it is normally done by the Snellen chart,
Mm,
but I am not sure that they would be available at the exam center or not.
mm.
So by asking with the 2 or 3 fingers at a distance of 3 meters or 4 meters, I'm not
Okay, any
sure.
other test other than VL equity?
Yes, I will do fundoscopy as well,
Mm.
and I will I would finish the examination by taking the blood pressures
Okay, doctor,
and
no need. They are same as
dip the
outside.
urine for okay, and dip the urine for glycosuria.
Hmm.
Uh,
Okay, doctor, 2 minutes are left.
okay, so Mr. Ali, do you have any concern?
Yes, doctor, can you please tell me what's going on with me?
Okay, Mr. Ali, from the details that I've gathered and from the examination that I've done, I have come to a point that might be there is a hormone in your brain that is over releasing, and that is causing all the symptoms, changing your facial features as well as causing the uncontrolled hypertension. We would run few tests on you, and then we would be able to give you more information on that.
Okay, doctor. So, is it curable?
Um, I want to tell you that the facial features or the bone tissues that have been damaged, uh, they are not easy to be recovered, and it is not easy to recover the facial features or the growth that has already that has already developed. But we can stop the progression of the disease by various methods, and I would be able to tell you about this in detail when we'll have the results of investigation.
Hmm. So, doctor, will you
Do you have
admit
any
me
other
today?
concern?
Will you admit me?
Um, I'll order some tests on the out as an outpatient basis, and then I'll arrange a meeting with you in coming week. Hope so, when the results are available with me.
Okay, doctor, time is over.
Thank you.
Okay, so tell me your positive findings in the history.
Um, well, I got the history, and the patient had the severe headache that was present all the time, 7/10 on severity, and there was also blurriness of the vision, and the blood pressure was not controlled with the medication according to the patient. Patient already also has gained some weight, and there are some changes in his facial features and some other features in his body. Um, on examination, I have seen the course, the uh, prognathism and the enlargement of hands and feet, as well as there is a uh, visual field defect, and
Have you checked for visual field
yes,
defect?
I did.
So, what type of visual field defect you got?
It was bitemporal homonymous hemianopia,
Okay, next.
and his visual acuity was also decreased. I was not able to do fundoscopy, and
Okay, doctor, how will you investigate? Okay, before this, what is your provisional diagnosis and your differentials?
my provisional diagnosis is acromegaly
Hmm.
as a result of increased release of growth hormone.
Hmm.
It might be some microadenoma or macroadenoma of the
Hmm.
pituitary gland.
Hmm. And
And
differential?
my differentials include pituitary microadenoma or pituitary macroadenoma. I am not able to recall.
Okay, how will you investigate?
Well, first of all, I will do some basic investigations like blood sugar levels, and dip the urine for glycosuria, and will check the growth hormone levels,
Hmm.
as well as the glucose tolerance test.
Okay, any other test?
And then I'll proceed to do MRI or CT brain, more so specifically MRI.
Okay, and how will you manage?
Pituitary microadenomas are usually managed with somatostatin analogs nowadays, and macroadenomas are managed surgically, transsphenoidal surgery.
Hmm. Any general management?
Yes, I will try to um, control the blood pressure of the patient by giving him some antihypertensives.
Hmm. Okay, doctor. Okay,
Okay.
doctor. Now I would like to add some points over here that yes, if you haven't seen the patient, then approach to headache or approach to such a case is not easy. But let me give you a tip or advice that whenever, especially in Pakistani centers, what happen is that whenever you enter the room, outside you get the scenario: patient is having headache, he is a middle-aged man, and he has hypertension. Only these two things you get now. And mostly in the exam they haven't given anything more now. They will not give you a full long scenario. This is what I experienced in my exam now. They will only tell you one or two things. Outside you will think about that headache. Okay, what can be the differential, what questions I have to ask, that's all. But when you go inside the room, since here you have to take the history from surrogate, uh, I just become a patient myself, because it may be a clue that the patient himself can come. There may be a possibility now. So in case if it is a surrogate, instead of just focusing on the surrogate, when you enter and just those few seconds before sitting on your seat towards the surrogate, must have a good look on the patient, his face, his hands, any exposed part, whatever you can get the information, you must have your close and keen observation on that. Okay, because it will give you
Okay.
quite much confidence. But in most of the cases it is not so. For example, in such case acromegaly, you can get the clue from this, because once you start the history you cannot see the patient will be on your side or on your back. All right, so let's start this scenario again. You get the presenting complaint of headache. I would suggest that instead of jumping to any comorbids or any medication history, just come in the sequence. Because what happens in PACES is that they need a sequence, structured and focused history. Okay, so first of all, you will perform the Lokira or Socrates of the headache, because whenever it is pain, you cannot apply the OD para. It is better to apply Lokira or Socrates. I hope you people know what is this. For example, Lokira stands for location, onset, quality of headache, intensity, radiation, relieving factor, and aggravating factor. Okay, and same goes for Socrates: site, onset, C for I think character of pain, then R for radiation, and any aggravating factors, relieving factors, and all that. No associations. So first of all, you will start from where exactly the headache is. Patient will locate that yes, it is frontal headache. Okay, what the patient told you in today's case now. Then okay, it's good you ask about the onset, quality of headache, but you didn't ask about how bad it is. The I mean, what is the character of the headache? Na? Is it dull, boring?
Yeah.
Is it throbbing? Is it sharp? Or what type of headache? Okay, and especially when you get the case of headache, when you are asking about aggravating factors, you should ask that whether this headache gets aggravated by straining, by leaning forward, by coughing or sneezing. Okay, because these are the red flags in the headache. These mean that there is some space occupying lesion inside the brain, okay, or something serious. And then, okay, relieving factor, radiation, that's good. Then you will come towards association. Instead of asking that what other symptoms, you will, because what happens is that in PACES they will not tell you, no? In other local exam they may tell you, because they are the patient, and they are not much taught about the exam. So here you should ask the symptoms yourself. And another thing is that try to ask one question at a time. For example, don't ask fever and fatigue. Okay, and lumps and bumps along with something else. Okay, because this is not liked by the examiner. Although we all know that we are short of time today, you also go more than 10 minutes for history. So this thing I would suggest that try to manage your time. So what will happen is that, and one thing more I want to ask Dr. Hamna, why you asked that are you right-handed or left-handed?
I do not actually I had to ask it to you. I took the class of Dr. Imran, and he always says that when you start the questions of CNS, always ask the patient right-handed or left-handed. I was not sure about it, and I had to ask someone
All right, but
that is it significant to ask or not?
actually, what happens is that whenever it is a clinical medicine exam, it is always examiner biased. This is noticed. You will notice even in the PACES that if the your examiner is lenient, he will give you marks accordingly. If your examiner is a bit strict, he will deduct your mark or not leave even 1 point. So we cannot say that this thing is not correct or this thing is not correct. Okay. So it is up to every person now. So what I suggest is that basically whenever there is a case of weakness of one half of the body, or whenever you are suspecting stroke, then in order to localize the lesion, then you ask. Okay, but it is basically examiner based, because in medicine you can't say this is wrong, this is right. It's not like maths now. So okay, this is okay. And then uh, in,
In that case, we can ask in this scenario as well, na? If there is a space occupying lesion, if we get the history
yes,
more,
if
so
you get the
we can ask.
aggravating factor, then you can ask.
Okay, okay.
Okay, then other things, for example, when you come towards the headache, try to localize it. Na? Okay, it is good that you ask about blurring of vision, na? But at the same time, ask about any bumping of in the into the objects. For example, when
Yes.
you were asking about pain, redness, or discharge from the eyes, also add this point as well. That blurring of vision, double vision, pain, discharge from the eyes, add this point as well. Any bumping into the objects. Okay, okay, then it will
Okay.
just give you a clue. For example, if because of stress of exam you haven't seen the patient even, but once you will ask this point, you will get confident that okay, might be the case, no? And when the I told you about pins and needles again, coming towards carpal tunnel syndrome like symptom in acromegaly, and weight gain, and okay, changes in appearance, you yourself examined while doing a physical examination. One thing, when you were asking about physical, I mean constitutional symptoms, ask about increased sweating as well, no? Okay.
Yes. Yes.
And when you were asking about past medical history, you explored about hypertension a bit more, because what happens is that we don't have enough time for the history. Now you just consider it like yes, it is hypertension. Okay, fine, because he's already taken 3 antihypertensive medications. So I think those few questions are quite a bit more. Na, do you check it from someone else or
Okay.
whenever you come to the hospital? Because what they will do is they won't give you a white coat hypertension in the exam. Na? So that's why.
Okay.
And another thing is that when the surrogate or the patient is telling you that it is affecting my life quite a lot, so always try to say that I'm so sorry for that. We will try to sort it out. We will try to help you. All right. Hello. I think she is muted. Okay, so Dr. Hamna, one thing I was telling about that you should say, I am so sorry that this is going on with you. We will try to sort it out. We will try to help you in this regard. Okay. And when he told you that yes, he is driving, at that time you will say him that I'm sorry you can't drive at this moment until we sort out your symptoms. Okay.
Okay.
And other thing is that when I show you the picture here, for example, in your exam, you see the patient. So try to be a bit more focused and structured examination. Your examination should be a bit slick, so that the examiners you will only get 4 to 5 minutes for examination. You will check for pulse. You will examine his hands. You will have a handshake, because what happens in acromegaly? They are large, doughy hands. They are moist. They have increased sweating, and also there can be when the patient told you their pins and needles, just quickly you will assess that whether there is any sensory loss in the hands. All right.
Okay. Would we perform Tinel's test or Fallon's test?
If you have time you can perform, or for example just make it your habit that when the patient told you there are pins and needles in the hands, you have seen the patient, he is you see, you suspect that he is having acromegaly, you should do Tinel sign or inverted prayer sign Fallon test at least one. Okay, it won't take much
Okay.
time now, so it will leave a good impression basically on the examiner. You should also look for finger prick marks, because although he hasn't told you now that he is suffering from anything else or diabetes, but and you couldn't for example tell you couldn't ask this question during your history that any increase waterworks, or do you have to wake up at night as well to pass the waterworks. Still you can see the finger prick marks and you can comment on it on your when you are telling your examination findings. Okay, so
Okay.
and this thing, the another thing I want to tell you is that acromegaly is an important cause of proximal myopathy. So when you were going towards the arms, you should at least
Mhm.
check for proximal myopathy. When you were coming towards eyes, before coming to eyes, you can check for acanthosis nigricans in the back of neck, because this is something very important cause of acanthosis nigricans is acromegaly. You can also look for
Mhm.
skin tags. They are also present in this patient. Then you can check the size of tongue. You will just ask the patient, just stick out your tongue outside for me, and you can see that yes, there is macroglossia. When you asked about any problem with your teeth during your examination, you can assess that there is increased interdental space or malocclusion of the teeth. You can also comment on prominent supraorbital ridges. For example, if they are not so prominent, but even if you will assess that patient has progantism, that is prominent protruding of the lower jaw, there might be a possibility that there is prominent supraorbital ridges. All right. And you can also comment on hirsutism. You can also since you will for example, if you haven't taken the history from the patient, still when you are taking consent from the patient, you can assess his voice. It can be husky or coarse voice because of acromegaly. All right. And in eye examination, I would suggest that in PACES exam, whatever the case is, instead of VL equity, VL field is more important. Okay, VL field and H movement. Okay, when you see the movement of the extraocular muscles, these things are more important than VL equity. All right, so you will check the tunnel vision during when you examine the VL field, and it is bitemporal hemianopia. All right, because hemianopia is something else, bitemporal hemianopia is something else. When you will ask the patient this finger test,
Yes,
moving
quite
test,
okay.
then you will assess that you can see the moving finger, but the patient cannot see. All right. So
Okay.
in the neck, you can assess for goiter as well, other than acanthosis nigricans and skin tags. And rest of the things, I would suggest that they are just that you can speak about. That, for example, I would like to check for apex beat for any cardiomegaly or any organomegaly. They will not deduct your marks now. But yes, it is very good. You have said that I want to do urine dipstick for glycosuria and fundoscopy.
Yes.
And rest all, I think you covered good, but try to answer the concerns in short and compact way, so that just come towards the point that the patient or surrogate will say, no doctor, I don't have any concern. So you will also get a relief that I have at least asked for all the concerns. Huh? And in investigations, try to be a bit more focused, because what happens is that they will check each and every skill during your clinical judgment. They will just assess that what other investigations you have missed. They can write in the feedback. For example, here you will start with random growth hormone levels and oral glucose tolerance test, serum IGF-1 levels, just as a screening test
Mhm.
for acromegaly. And meanwhile, you will tell that what you want to look for in those tests. You will go for MRI head, not CT scan. Okay, MRI head or MRI
Mhm.
pituitary fossa. And you can
Mhm.
also add that I would like to I would like to order a complete pituitary hormone profile. All right, and VL perimetry scan. And another important thing I want to tell you here, that what happens in cases, they would like to, for example, whenever you get a case of acromegaly or you are preparing for it, always try to rule out men 1 syndrome. All right, multiple endocrine neoplasia. I think less than 1 minute is left, and then I will share another link. I couldn't install Google Meet because I was Dr. Hamna, are you there?
Yes, Dr. Mubashir.
So I was discussing a point, multiple endocrine
I'm unable to
neoplasia.
hear you.
Am I audible now?
Yes, doctor.
Okay, so we were discussing a point, that is men one. When, for example, whenever you get a case of acromegaly, because it might be a cause, underlying cause may be pituitary adenoma. So always try to rule out men one syndrome, that is other features as well. For example, uh, you will ask about pancreatic tumor. Okay, you may ask about that any history of loose motions of watery consistency, or for example, you may ask about parathyroid hyperplasia. Only one question about hypercalcemia: that are you passing more water work than normal? or than usual. Okay, this question will not only cover your diabetes, it will also cover your hypercalcemia. All right, and in investigation part, I think you have okay. One point is that you can ask about, you can say to the examiner that I would like to do perform colonoscopy in this patient after full assessment because as acromegaly can be a link for colorectal carcinoma. All right. And always start from general management. In general management, first line should be patient education, counseling, and explanation of the disease, and education of the caregivers and family as well. Then you will say that yes, I will regularly monitor his blood pressure and blood sugar level because once acromegaly will be treated, only then the hypertension will be treated. All right, because he's already taking too many antihypertensive medications. And for his real problem, you can give him the aid of prism glasses. All right. And another thing is that you will say that I would advise the patient to avoid driving and multidisciplinary team management with involvement of endocrinologists, eye specialists, psychiatrists, as well as cardiologists and specialist nurses and occupational health physician as well. All right. And during pharmacological management, apart from somatostatin analogs, also mention about dopamine analogs and growth hormone receptor antagonists. Rest
Okay.
is okay. All right. So this was all about our first long clinical consultation. Now let's move towards the second.
Doctor, I have a question. If
Yes,
you
yes,
can answer, please.
yes, yes.
Uh, if there is a scenario where we will have to perform the visual acuity,
Yeah.
so how will we perform in the absence of Snellen's chart?
You will do the finger method. You will ask the patient just close your
Finger
one
method.
eye. Yeah. And how many fingers are there? He will say one, two. Just rough method. All right. Because you have total
Okay.
5 minutes for examination, or maximum 6 or 7. But you don't have to perform only real equity. Now you have to perform other steps as well. So finger method. This is what uh, I perform while my preparation. All right.
Okay. Or and at what distance? 3 or 4 meters is an okay or something else?
I think 3 4 meter is quite a long distance. No? At least only one finger, one arm length. It is okay, one arm length.
Okay. Okay.
So, Dr.
Thank you.
Saista, are you there? Welcome.
Doctor, I have a question.
Yes, yes, please.
Can I ask? Yes, regarding the fundoscopy, is it important to do this fundoscopy or just to offer at the end?
Actually, doctor, what happens is that it is best if you perform the fundoscopy. But what I have seen in international sector, especially in Pakistan, that they have the light system in such a way that it is not controlled in your room. That's why for a proper fundoscopy, you have to have a dark room. But once it is such a scenario that fundoscopy is quite necessary to perform, they will give you such. Uh, so at least it is very best if you perform. Otherwise, if it is such a case, for example, if it also involves so many exam steps, then they can also examiners are mostly lenient.
Okay,
Alright.
doctor.
I have a question, Dr. Mubashira. Can I
Yeah.
ask?
Yes, yes.
Well, once you diagnose a case, like based on your history and the symptomatology that you explored is headache. Once you explore that, and once you come to a conclusion that okay, this is a case of acromegaly. So, is it relevant, to ask all the questions in the scheme that is given, or just go or targeted questions just to rule out some differentials and then focus on the rest of the scheme and then, save your time for examination? Would
Yes,
that be
okay.
an appropriate approach?
Exactly. This is the approach. This is the structured approach, basically. No? I don't know what other questions you are talking about. If you are talking about some systemic review, then yes, systemic review.
Basically, I'm talking about like if it was headache and hypertension, and you didn't. If there will be a patient, so you have to throw an eye on the patient, just eyeball and just see like how the patient look in general appearance. If it's a syndromic patient, so then you can pick like in case of acromegaly or anything else.
Hmm.
Apart from that, once you come to see that, okay, this is the case, and then you go targeted with the questions like, you ask about the acromegaly and you exclude some other endocrine causes and some other causes for that matter if the patient has a positive past medical history or any surgical history for that matter. So you just roll around those questions and you just follow the scheme, and then you just go for the examination. So I was like, it might save some time. Or if it's like, I don't know about the Pakistan, because I've been in Ireland, so, and I'm giving exam in Pakistan, so yeah, this is a big difference for me. Over here, like, they go targeted, they go they examine targeted, and in Pakistan we follow the schemes, especially that are made, the books and everything. But you don't have that much sufficient time that that you can ask every question. As you mentioned that it was quite irrelevant to ask that are you left-handed or right-handed. Like if examiner asks you that what was the relevance of this question, then we have no answer for that. Like in this case, I'm so sorry about this. Yeah, so can you like
You are quite right. This is basically the thing which cases examiners want. This is the structured history and this is actually focused history. So I always suggest that whenever you come towards the diagnosis early in your history, for example, just at looking at the patient or after just OD para or a few questions about associated system, just try to complete that system questions. For example, here if it is CNS, then you can just complete the CNS, few questions of CNS or endocrinology questions. Then you will go towards your journal questions, 5 to 6 journal questions, and then towards past history, allergic medication, and family history, and then your social history. This will cover 6 minutes, and then you will have enough 6 to 7 minutes for your examination. This is a good thing basically, because what happens is that if we talk about all the skills, uh, what happens is that in your 6 minutes, or for example, as many candidates always spend too much time on the history, you have covered only 4 marks out of 28 marks. They can at least give you 4 out of 4 till 11 minutes, nothing else. Or just like, for example, maintaining patient welfare, they can assess during that. Otherwise, when you start
I'm so
examining,
sorry. I'm so
yeah,
sorry to cut you off. Actually, there's a little bit of buffering from your side. Please, can you fix it?
I don't know what is the problem. Basically, I am using the microphone. Maybe that problem. Is it?
Your voice is not like clear. I cannot like hear you properly.
Is it okay now?
Yeah.
Okay. So basically, I was saying that this is a good approach which you were talking about. This is basically the history which the basis examiners want from you. They just want a structured history. They don't want you to become haphazard and go here and there from one system to another system. If it is good that you just look at the patient and you come towards the diagnosis, or you just complete your diagnosis in the OD para, then it is a very good thing that you just ask about that system questions, then general questions, and jump towards past history, allergic medication, family history, and social history. And then you will have good time for examination, because there are many steps in the examination which you need to do, and it will require at least 6 minutes, so that you can have 2 to 3 minutes to manage your concern. Because if you look at the mark sheet of cases, here you can see that clinical communication skill, which we spend 10 minutes while taking the history, it only has 4 marks. If you want to get satisfactory marks, it is only 4 marks. Once you start examination, then your 2 skills will be assessed. Instead, 3 skills will be assessed. That is physical examination, identifying physical signs, and maintaining patient welfare. And after that, your next skill, clinical judgment. Instead, clinical judgment will come when you will give the viva. You will have only 2 minutes for your concern. So accordingly, if you manage your time properly, 6 minutes history, 6 minute examination, 2 minutes for viva. And in 6 minutes, only if you remain structured and focused, only then you can complete your history in 6 minutes. Because it is not possible by anyone if they ask all the questions and they say that they can complete it in 6 minutes.
Right,
hope.
Dr. Mubashir, thank you so much. Yeah. Well, I have another question. Like, if once we are done with the history and we are approaching to the examination, can we just ask the patient, like, do you have any concerns for me so far? And then we proceed with the examination just to save time, and just if then we forget about the concerns. So can we ask, like, in between the examination and the history, just proceeding towards the examination, that do you have any concerns for me?
Okay, Dr. Hiba, actually what happens is, as you said that you are coming towards Pakistan to give your exam. Here I would
Yeah.
suggest that do not do this, because this is what I have experienced from my seniors, that
Mm-hmm.
while you are taking history from the surrogate, because here you have to take the history from surrogate, because mostly the patients are
Yeah.
local, so they don't
Yeah.
understand English. So it will look quite a bit weird that you will the surrogate is sitting at a distance and the patient is
Mm-hmm.
sitting at a distance. So you can't do this. Na?
Okay.
This is not practically possible. So I would
Mm-hmm.
suggest that take a history. After that,
Mm-hmm.
when you are taking doing examination, just focus on the examination, because you have to give command to the patient as well. And what happens in Pakistan is that uh, they will tell you that you can continue in your local language. For example, whenever the candidate is talking with the patient, he will speak in Urdu. So
Right.
there you can't take the history na, at that time, or you cannot manage the
All right.
concern. So it is good whenever the examiner will say 2 minutes are left. So there you should come towards the surrogate again and ask for the consent. All right?
Okay, so that will be like an alarming thing for us. Like, if they say 2 minutes left, so that we just straight away go for the concerns, leave
Yes.
everything beside, because it has its
Yeah.
own mark.
Yes, it has its
Yeah.
own marks, but let me tell you one
Yeah.
thing from my experience, that
Right.
this is not so much necessary that you should just say leave everything, no? Because
Mm-hmm.
I think a couple of days ago I was sharing a scenario of multiple sclerosis. This was my case basically, no? So what happened when the examiner said 2 minutes are left? I have done the examination of lower limb as well as upper limb, but my eye examination was left at that time, and I couldn't have picked internuclear ophthalmoplegia and nystagmus if I just stopped that examination. But luckily, Alhamdulillah, it was from Almighty Allah that I performed that examination. It was a classical internuclear ophthalmoplegia as well as nystagmus, and I was quite confident about it. And then I came back. Maybe it was 1 minute 30 seconds left for my concern, but still, it was good for me. So, in case if there is some clue left and still you are not so sure of your diagnosis, so it is not so bad that you spend 10 to 20 seconds more. Okay?
Right. Right. Thank you. Thank you so much.
Okay, welcome. So, Dr. Shaista, are you here?
Yes, doctor, I'm here. I'm here, doctor.
Just one minute. So, I have already sent you the scenario before just to save time. So, can you please read
Dr.
the scenario
Bashra,
again?
your sound is not clear and there is a background noise. I think your headphone, because of this headphone, there is, some
Okay,
noise
let
is
me remove
there.
this. Let me remove this and then please tell me if it is clear. Is it clear
Yes,
now?
it's better.
But now I couldn't. Hello, am I audible now?
Yes, doctor.
I think because I am logged in since from this laptop, so I think I gave him the command that I will use my microphone. So whenever I remove my microphone, it is not working. Is it audible?
It's so muffled that difficult to understand. Is it for me only or others also? Maybe I have any problem.
No, no, it's a bit of a preference from your end.
Hello.
Yes, hello, doctor.
Hello.
Hello, yes, doctor, hello.
Am I audible now?
Yes, you are audible.
Okay, doctor, please bear with me today. I will change my headphone or something like that for
No
tomorrow.
issue, doc. No issue, not at all. It's okay.
So can you please read the scenario?
Yes, a 40-year-old Mr. Zia presented with presenting complaint of backache for 1 month. His lab and vitals are given below. Please take a structured history focused examination and manage the concerns. Vitals are blood pressure 120/70, pulse is 72, labs ESR is 55.
So are you ready?
Yes.
Okay, so your time starts now.
Hello there. Hello.
Hello, I'm not audible.
Now I can listen you. Hello there.
Yes.
I'm Dr. Kamar, one of the doctor in this ward. Today I will take complete history from you and I will write them some notes that will be confidential. Will that be all right?
Yes, doctor, all right.
All right. So before proceeding further, may I confirm your identity? You are Mr. Zia, 40 years old.
Yes, doctor.
Okay. So Mr. Zia, can you please tell me what brought you here today?
Actually, doctor, what happened is that I have been suffering from backache, and it is quite much intensity
Mm-hmm.
since the last 1 month, and it is bothering me a
Mm-hmm.
lot. That's why I'm here.
Mm-hmm. Can you please tell me more about it?
Doctor, actually, I have been suffering from this backache for 2 years, and I was
Mm-hmm.
taking some painkiller medication for it, but now it has reached to such an intensity that it is impacting my daily activities.
Mm-hmm. I'm so sorry to hear about that, Mr. Zia, and I'm surely will try to sort it out. So that backache starts from 2 years back, and now since last 1 month, your pain is getting worse, right?
Yes.
Can you please tell me where exactly you are having the pain?
It is at my lower back.
Okay, and is it going anywhere, like towards your thighs or towards upside?
No, doctor, it is not actually going anywhere. It is just over
Mm-hmm.
there
It's just what?
in the lower back.
Okay. And what's the nature of this pain? Is it dull, sharp shooting,
Actually, doctor,
or
it is dull. It is dull.
mhm. Okay. And if 1 is minimum, 10 is maximum, how much you will grade this pain?
It is 7 out of 10.
I'm so sorry for that. Are you comfortable to talk? Is it okay for you?
Yes, doctor. Yes.
Okay. And did you feel anything which make it worse, like doing any activity or early morning?
Actually, doctor, activity makes it better, and rest
Mm-hmm.
make it worse.
Mm-hmm. Do you have any stiffness early in the morning?
Yes, doctor.
How long this stiffness persist with you?
Almost 1 hour, 30 minutes or 1 hour.
Mm-hmm. Mm-hmm. Okay. And is it associated with any difficulty of getting up from the chair?
Uh, no, doctor, not exactly.
Any numbness or tingling sensation? Any numbness or tingling sensation anywhere?
No, doctor, no.
Okay. Is it difficult for you to hold your urine or your bowel?
No,
Okay. So is there any change of your weight?
no,
Any change of your appetite?
no,
Any lumps or bumps in your body? Any lumps or bumps in your body?
no, no,
Okay. Do you feel dizzy while getting up from sitting position?
no,
Do you have high body temperature?
no,
Do you feel tired?
No.
Anybody told you look pale than before?
No.
Okay, is there any traveling, recent traveling? Is there any recent traveling?
No, doctor, no.
Any trauma to your back?
No.
Okay, do you have any sweating? Hello?
No, doctor, no.
Okay, and all right. So do you have any past medical history I should be aware of?
No, doctor, other than back pain, no other history.
Like high blood pressure, high sugar,
No.
any other joint is affected with this back pain?
Yes, doctor, my right knee is also affected.
And since how long?
1 month.
All right. Is it getting worse with activity or with rest?
It is always there. Nothing makes it better or worse.
Is there any trauma there?
No.
Can I see the joint?
Yes, doctor.
Is there any swelling, any redness?
Yes, doctor, you can see
Okay.
a bit swelling. It is warm, but no redness.
Okay. Do you have any rashes anywhere?
No.
All right. And any oral ulcerations?
No.
And are you taking any medicine over the counter or prescribed medicine?
Paracetamol, no other medicine.
And it's not your pain is not improving with paracetamol, right?
Yes, doctor, in the start it was improving, but since last 1 month, there is no effect.
Okay. Is there any family history I should be aware of?
No, doctor.
All right. Is there any shortness of breath?
No.
Any cough?
No.
Any redness of eye?
Not at the moment, but it was there almost 6 months ago.
Okay. And how it was treated?
I went to a eye specialist. He gave some eye drops.
All right. Do you have any change of your bowel work? Sorry?
No change in bowel work.
Any tummy pain?
No.
Any change of your water work?
No.
Okay. So I would like to ask some personal question. Will that be all right?
Yes, doctor.
All right. So do you smoke, Mr. Zia?
No.
Do you take alcohol?
No.
What you do for your daily living?
Actually, doctor, I'm a clerk.
Is it affecting your daily life?
Yes, doctor, it is affecting because whenever it is very difficult for me to sit for a prolonged period of time. So it is affecting my daily life and my job as well.
I'm so sorry to hear about that, and I will surely help it out. If you need, we can give you some leave letter. Okay.
All right. Thank
Do you have any racing pacing of heart, Mr. Zia? Is there any racing pacing of heart?
Yes, doctor, sometimes.
Okay. Any shortness of breath? Any shortness of breath?
No, doctor, no.
Hello. Okay. So I would like to examine you. Will that be all right?
Yes, doctor. Let me show you
Okay.
a
So
picture. Just a minute.
okay.
Okay, you start your examination meanwhile.
Okay. So a journal look to a patient. Okay. Then I want observational chart. Is it same as outside?
Same as outside.
Okay. And then I come to the hand quickly, and I'm seeing if there is any small joint tenderness or swelling, any redness, any rash on surface, any nail changes. Okay. Then I would like to check the pulse. Is it regular?
Yes, doctor, it is regular.
Okay. And I would like to do the collapsing pulse.
Yes, doctor. Its collapsing pulse is not present.
Okay, and now I come to the eyes, and I'm looking, is there any anemia, any redness, any dryness?
No, doctor. At this moment, there is no redness. Can you see the picture?
Yes, I can see.
Okay.
Okay, and now in oral mucosa, I would like to see any sign of anemia, any oral ulcerations.
No anemia, no oral ulceration.
Okay, now I would like to request to the patient, if he is fine, can I do the wall trackers test?
Yes, doctor.
Okay, and I generally inspect the back as well, if there are any tenderness, any swelling, any sign of trauma, any scar mark. Okay, I can see that this patient is having loss of lordosis, and the trackers, I think the trackers and wall distance would be more than, I forgot the measurement, but it is more. And now I would like to do Schauber's test, and also I would like to check the limitation of lateral movements.
Yes, doctor. There is limitation of lateral movement, and Schauber's test
Okay.
is also positive.
Okay, and I would like to assess the gait of the patient, if he is fine
Yes,
to do
doctor.
it.
He has two question mark posture.
Okay, all right. And now I would like to, with my help, I would like to make her sit again. Okay, and would like to see if any visible pulsation in the neck, and if there is any murmur.
Yes, doctor. There is no murmur and no visible pulsation.
Okay. Okay, then I would like to auscultate the chest, especially upper zone.
Yeah. Apex auscultation is normal.
Okay, normal. And then no need to examine abdomen here. I would like to see the knee,
Yes, doctor.
where this tenderness is there. So is there any swelling,
Yes, doctor. There is swelling. There is increased warmth,
redness?
but no redness.
Okay, okay. And is it okay if I can move it? Just see if there is any cracked sounds or any limitations of the movement.
Actually, doctor, there is limitation of movement, and it is quite painful to move.
Okay, and is there any other joint involvement, like ankle swelling or anything?
No.
I would like to check Achilles tendinitis.
Yes, doctor. How will you check?
I think I need to tap at Achilles.
You will press the Achilles tendon. Okay.
Yeah, press. Okay, press. Is
Yes,
it
doctor.
positive?
Yes, doctor. It is painful.
Okay, and quickly I will just see the planters. Hello?
Yes, they are downgoing.
Okay, so Mr. Zia, can I ask some personal question? Will that be all right?
Yes, doctor.
Are you sexually active?
Yes, doctor.
Okay, and do you have regular partner or casual partner?
Yes, doctor. My wife only.
Okay, do you have kids?
Yes, doctor. Two kids.
Okay, is there any chance, I mean, do you use any party or recreational medicine drugs?
No, doctor.
May I know your concern?
Yes, doctor. Can you please tell me what's going on with me?
Okay, so it looks like you are having a condition. I appreciate your concern, Mr. Zia, and it looks like you are having a condition which we call ankylosing spondylitis. This is a medical term, and it's a medical condition in which there is a defense mechanism become bizarre, and this is start acting towards our joint, especially no, it's not a defense, it's a soreness of the joint. It's a soreness of the joint, especially your back, and it can involve this disease can involve other parts of your body as well, like your lungs, your eyes, your heart, your skin, and other joints. So Right now, since you have this since last 2 years, so since last 1 month it get aggravated. So what I'm going to do is I will go to admit you, okay, and we'll run some tests, we'll do imaging, and will involve joint doctor, okay, and yeah, do you have any other concerns?
So, doctor, is it curable?
It's a manageable condition, and we can manage this under a team of doctors, which include joint doctor, physiotherapist, occupational therapist. Okay,
Okay.
it cannot be completely treated.
So, doctor,
Do you
can
have
it
any
run
other
in
concerns?
family? Does it run in family? Can my kids have it?
Okay, it does not run in families, but as you are suffering from this disease, so your kids will have more chance to develop this condition uh, compared to normal population.
Okay, doctor, time is over.
Okay.
So, can you please tell me your positive findings in the history?
In the history, okay. So this patient is having back pain since last 2 years, and which was relieved early with paracetamol, and now it is getting worse since last 1 month, and the pain is at lumbar lumbar area, okay. And the severity right now, the severity is 7/10. There is apart from that, in history, uh, this pain is getting worse early in the morning, and there is stiffness which persists for more than 30 minutes, okay. And on examination, I have find out that this patient is having um, uh, this patient is having normal vitals, and there is loss of lordosis, and there is a this what we call this double question mark appearance, okay. Schober test is positive, and there is limitation of movement, and there is no collapsing sign, collapsing pulse. There is no apical fibrosis. Also, patient gave me history of anterior iritis or uveitis 2 or 3 months back. Right now, patient's eyes are okay. There is also um, right knee pain, which is right now swollen and inflamed. So, on basis of my history and examination, my first differential for this patient is ankylosing spondylitis, acute flare of ankylosing spondylitis.
And differential?
Other could be other could be, I can put as it is inflammatory. So ankylosing spondylitis. What else? Other inflammatory? I think I can put here osteomalacia.
Okay. Any other differential?
And yes, I can put any enteropathic arthritis, but against that there is no change of bowel habit. Yes, psoriatic spondylitis, but against that there is no rashes or ulcers anywhere, no nail changes.
Okay, doctor, how will you investigate?
So I would like to do a journal investigation, which include complete blood count to see if there is any anemia, any infection. ESR is already done, which is 55. I would like to do CRP and liver function, renal function, urea electrolytes, urine DR. And specifically, I would like to do X-ray of the back. If needed, I would go for MRI back. And for the knee, I would like to do if there is soiling and if there is fluid. So I would like to do first X-ray, and then I can aspirate the fluid and will send for cytology, cells, and crystals, microbiology. And apart from that, I would also want to do chest X-ray of this patient, ECG also, to rule out any complications of ankylosing spondylitis.
All right. So how will you manage?
Okay. So the management would be pain management and a multidisciplinary team approach, educating and counseling of the patient regarding the underlying condition, involvement of specialist, rheumatologist, physiotherapist, and there is racing pacing of heart. So I would like to involve a heart cardiologist also. And treatment would be patient is already taking paracetamol, so I will escalate the treatment. And right now patient need steroids, and we can put patient on disease modifying drugs like methotrexate and azathioprine. If it is not settled with two DMARDs, so we can go to biologics as well, monoclonal or TNF inhibitors. Yes.
Okay,
And
Dr. Time is
exercise.
over.
Okay.
So, Dr. Shaista, overall, a very good attempt, I would say. And we will discuss this in our next link because only 1 minute is remaining. Okay. So
No
let me
issue,
share.
doctor.
Let me share another link in a couple of minutes. All right.
Okay.
Hello, everyone. Am I audible, Dr. Shaista?
Yes, yes, doctor.
So let's start this scenario. Let's start the discussion. You took a very good history. This is quite a good thing that you completed it in time. I just want to share a few points over here that one thing which I noticed that you missed is heel pain. Other thing, mostly you have covered everything. Huh? Heel pain you can ask, all right, because since it is a condition which can be associated with plantar fasciitis and Achilles tendinitis. Other than that, I think you have covered each and everything. You asked about history of trauma, fall. Yes, it is a good thing. You remain focused during your history. You used the word ulcer. So ulcer is considered a jargon by most of the examiners. So it is better that you use the word mouth sores. Instead of oral ulcers, use mouth sores. All right. And rest you have covered each and everything. I think just a few red flags of the back pain which I need to mention here are that any weakness of the legs, any difficulty in walking, or and I think you have asked about loss of bladder and bowel control and numbness, tingling, or pins and needles. All right, or any weight loss. Yes, you have covered that as well. So during your examination, I think you have covered each and everything. Just try to be, for example, once you will do your revision and you will revise, you will do this that the posture of these patients of ankylosing spondylitis, it is stoop question mark posture. They have fixed kyphoscoliosis. They have sacroiliitis. You should check for sacroiliac joint tenderness when you are examining the patient's back as well, and loss of lumbar lordosis, or there can be extension of the cervical spine. All right. And
Yes, yes.
when you were checking for lateral movement, also check for flexion and extension of the spine as well as cervical movement. You can ask the patient whether he or she can move his neck. All right. And no need to remember occiput wall distance, just you will mention that yes, the occiput wall distance is increased. All right, and modified Chauvis test will itself take 1 minute or 1.5 minutes. All right, and rest all your examination was quite up to the mark. Uh, and one thing you were mentioning in management plan, yes, there can be misdirected defense system. in ankylosing spondylitis, because HLA-B27 antibodies can be positive in such patients. And when the
Yes, yes.
surrogate was asking about the concern that whether it can be passed in his family, so there might be a chance that it can be passed, because you were mentioning now that your kids may have increased tendency to have this disease because of this HLA-B27 antibody. There can be a chance that the first degree relative can be affected, although the chance is not very high, but still there is a chance. All right. And in your management plan also include genetic counseling and HLA-B27 antibodies in your investigations, because it is mostly, I think it is 90% positive in patients of seronegative spondyloarthropathy or
Yes.
ankylosing spondylitis. And when I was asking about differential, you can give the differential of seronegative spondyloarthropathies, including, yes, enteropathic arthritis, psoriatic and reactive arthritis and Rita syndrome, etc. All right. And yeah, another thing, I think you haven't left anything. Sport groups or ankylosing spondylitis societies, you can add. Rest all you have covered. So this was all about this case, because Viva takes only 4 to 5 minutes, in which almost 2 to 3 minutes goes around your history points, your your examination, and your differential diagnosis. So, any questions from anyone?
Doctor, can I ask?
Yes, yes.
So management, as I escalate the management, so that's the correct management, right?
Yes.
Physiotherapy, great exercise, and right now patient is having a flare, so we can give steroids and DMARS and then biologics.
Yes, doctor, it is good. But I think steroid role doesn't come in ankylosing spondylitis. It is paracetamol, NSAIDs, physiotherapy, swimming, exercises, and then counting odds.
No, this patient is having acute flare, so for that intraarticular steroids, I think can
Yes,
give.
yes. For knee joint, you can give intraarticular steroid.
Okay, and the knee joint pain is because of osteoarthritis, right?
No, it is actually because of ankylosing spondylitis, because ankylosing spondylitis can also involve your other joint, other large joint as well. So it is also
Okay.
because of ankylosing spondylitis.
Okay. Okay.
Hmm. Okay, so any other question from anyone? Or I will stop this meeting. It is already too late here.
Thank you, Dr. Mubashira, for giving me the chance to do the case.
Okay, welcome. No problem.
Doctor, I'd like to just say one thing.
Yes.
Regarding investigation, we also have to say the HLB27 test, right?
Yes.
Okay.
Yes, over here I remember one point, Dr. Shaista, you were telling about X-ray lower back. Okay, instead of saying that, you can say X-ray lumbosacral spine, and similarly MRI lumbosacral spine.
Yes, doctor. Actually, at that moment, I forget the
Yes,
name
yes.
of joint, lumbosacral.
Yeah, I also thought of that.
Yeah, lumbosacral. I forget what that joint is called, so that's why I said lower
Yeah,
back.
it's okay.
I was, yeah, I just don't want to make any mistake to say any wrong
Okay,
joint. Yes.
okay, fine, fine. So, thank you everyone for participation. If there is no question, I will stop here.
Thank you, Dr. Mubashira. I just want to add up one thing that can we get these kind of like these cases? I think we might be encountering these cases as a local cases in Pakistan centers, like in India or in Lahore for that matter.
Yeah.
So do you have an idea, like, how to focus our examination based on the locality? Because, in here we have a lot of cases with a lot of everything present almost in like every patient. They have complex history and they have complex diseases as well.
Hmm.
But I don't think so in Pakistan we'll be getting such kind of, complex cases, I would say, or they are even there. So can you just, brief us about like how to, uh, focused or cases or focused or examination rather than dwelling into every single case that we encounter. Can you just throw some light on that, please?
Yes, doctor. Here as well, patients are quite complicated. Many different things are present in them. For example, I would suggest that whenever you get the diagnosis in your history and you are starting your examination, try to do each and every step. For example, here, as Dr. Shaista was doing, she was doing quite well. You will start from general physical examination, then you will come towards your main focused examination, and you will perform all the rheumatological examination which is concerned with your case. And since it is ankylosing spondylitis, so she also tried to focus on the extra-articular manifestations of this disease. For example, when she was checking for anterior uveitis, she was checking for apical fibrosis. Down, she was checking for aortic regurgitation or any other AV block. And similarly, she was checking for Achilles tendinitis. So basically, what happens is that whenever in the exam they put such patients who have quite evident physical sign, which can be picked quite easily if the candidate perform all the steps step by step. All right. So whatever your case is, after performing general physical examination, come towards that system and follow the scheme, and you will not miss any finding if you are quite well practiced. Is that clear?
Thank you so much. Inshallah,
Welcome.
we'll practice. Thank
Okay, everyone. Thank you so much. Allah Hafiz.